reflect the views of the presenter, and they do not necessarily reflect the official views or policies of the Department of Drug and Alcohol Programs or the Commonwealth of Pennsylvania. Next slide. As you can see on the screen, we have quite a few learning objectives for the day. I won't go through them all, but as you can see, our hope is that you'll be able to recognize the clinical effects and withdrawal symptoms associated with medetomidine exposure, identifying the risk and management considerations for patients presenting with medetomidine withdrawal. And also, by the end of the session, you'll be able to identify when escalation of care and coordination with hospital-based providers is needed. Next slide. It is my pleasure to introduce today's speaker. We have Dr. Michael Lynch. He is an associate professor of emergency medicine, toxicology, and addiction medicine at the University of Pittsburgh, where he works clinically in several UPMC hospitals. Dr. Lynch has implemented buprenorphine induction processes, naloxone test strips, and buprenorphine to-go programs, warm handoff services, inpatient addiction consult teams, and expanded hospital-based treatment services. He is currently Senior Medical Director for Quality and Substance Use Disorder Services at UPMC Health Plan. He is the founder and director of the UPMC Medical Toxicology Telemedicine Bridge Clinic, where he has served patients in 65 Pennsylvania counties during more than 15,000 encounters since 2020. Please welcome Dr. Michael Lynch.
Thank you, Secretary Davis-Jones. Appreciate it. And thank you all for joining today. I was watching the chat and I'm going to close it for the moment just because otherwise I'll keep watching it. But great to see so many folks from all over the Commonwealth and beyond. And actually also thank you very much for submitting questions ahead of time. They were excellent questions and I think follow along with hopefully what we intend to cover today. But I will certainly try to do so as well as I can. So with that, I will move on. We'll talk about our medetomidine. These are some of the specific objectives Secretary Davis-Jones went over, and don't want to spend more time talking about objectives, and let's jump into the meat of it because I know that's why we're all here. So we did get some questions about it, and I typically lead off with, sort of where is it? And then we'll get into what it is and then what it does, and then finally how we treat it. So medetomidine has been detected basically everywhere in the U.S., but you can see the Northeast is by far the most prevalent area. This is from CDC, so looking at through 2025. This was just their Health Alert Network alert that came out a few weeks ago. So, 3/4 of the drug supply in the Northeast, and a lot of that really is heavily focused in Pennsylvania, frankly. So Pennsylvania and particularly Philadelphia to start, and then rapidly following Pittsburgh, and then sort of spreading throughout the state has really been the epicenter for medetomidine, but it has been identified throughout the U.S. So if you're joining us from somewhere outside of Pennsylvania or outside the U.S., or even in some parts of Pennsylvania where we're not seeing it a lot yet, you can anticipate you likely will. I want to highlight some drug checking data, it's really important to call out that drug checking data was really important for us as we were trying to figure out what was going on early on. And PA Groundhogs is a great source. There are other sources, CFSRE and Alex Kratulski, as well as Nav Dasgupta's lab at UNC. Lots of different sources of drug checking data that were really informative to let us know what we were seeing and when. And so these are samples that have been submitted over the last few years as fentanyl. Basically, people purchased as fentanyl, and that's what they thought they were getting. So you can see fentanyl was present in most, but I will highlight not all samples purchased as fentanyl. And medetomidine was in none of them until the second quarter of 2024, whereas you can see the darker the red, the more present it was. You can see xylazine was approaching, 100%, certainly in Philadelphia and kind of throughout the Commonwealth. And then starting in mid-2024, we saw a transition to much more medetomidine and much less xylazine. I'll also note, though, that xylazine did not go away completely. I think we had some expectation that it might, but it did not. It sort of, decreased and then actually increased a bit, and is kind of staying present as well as medetomidine. But in the first quarter of 2026, the data reported by PA Groundhogs, about 80% of fentanyl samples in Pennsylvania submitted had medetomidine, and about a third had xylazine. So you can imagine there's a lot of overlap there. And this is really helpful looking at it across the entire Commonwealth, but also understanding that the Commonwealth is large and drug supply and samples and prevalence are very different in different places. So getting localized data can be very helpful as well. So in Allegheny County, where I work, we can see here that even xylazine was actually only minimally present even through 2022, despite in 2022, if you took samples in Philadelphia, almost all of them would have xylazine. And then by 2023, more than half of our samples had xylazine. And then 2024, we started seeing medetomidine and xylazine separately as well as together. And then by 2025, more than 70% of samples submitted in Allegheny County had medetomidine. About half of those also had xylazine, and we still had some samples with xylazine only, and really only a few that didn't have either or in them. And you can see all the other different things, both in the PA Groundhogs and the Allegheny County reports, of all the different things that are included in those samples, including heroin, which is still actually present, though to a small degree. And then looking at Philadelphia, and I highlight Allegheny County and Philadelphia mostly because that's where we have the most detailed localized drug checking data outside of entire Commonwealth data. And Philadelphia had a similar sort of breakdown, and these are based on first half and then final quarter of 2025 available. And Philadelphia does a great job with their drug checking reports. And you can see in the first half of 2025, about 2/3 had medetomidine only, but about 80% had medetomidine total, 13% had xylazine. And then by the last quarter of 2025, more than 90% of the supply in Philadelphia had medetomidine. And again, about half of that also had xylazine. So xylazine definitely has not gone away, but medetomidine is the most prevalent adulterant in Pennsylvania. So now I'll get a bit into what is the medetomidine, and there were some questions about the pharmacology and how it compares to something like xylazine, both in wounds as well as acute toxicity. So medetomidine is what's called a racemic mixture. So it's a mixture of both levomedetomidine and dexmedetomidine. And what that means is dexmedetomidine is the pharmacologically active portion of that. The levomedetomidine is sort of there for the ride. It doesn't really do much. So if you take a milligram, we'll say, of medetomidine, about half of that is dexmedetomidine, and that is the active dose, if you will, so half a milligram. And so anytime if you ever see quantitative data about medetomidine, you can sort of cut it in half, and that's sort of the effective dose. So in humans, dexmedetomidine is something that we use in ICUs and ORs to treat agitation, to help with sedation, particularly in critical care management. But it is separated from the levomedetomidine, and that is what's approved. But for veterinary use, that combination of levo and dexmedetomidine, or medetomidine, is approved for anesthetic, essentially, for veterinary purposes. So it is available in that form. We get a lot of questions about where does it come from? Does it come from the veterinary kind of diversion versus kind of separate sourcing from overseas? I'm not the best person to answer that, but what I have been told is that I think a pretty small proportion would be related to diversion of veterinary supply, and probably more supply from external sources specifically for this purpose. But again, I'm not the expert on that, but we do get a lot of questions, and there were some questions submitted about that. Also want to note that I've shown structures for other common common drugs here. So xylazine in particular, we're aware of. Clonidine, we'll talk more about. Tizanidine, which we used for xylazine withdrawal symptoms. And you can see structurally they're very similar. But what's different is the dexmedetomidine is much more potent. It sort of binds to the alpha-2 receptor in our blood vessels in our brains much more tightly than something like xylazine, and creates much stronger effect. So you'll see different numbers, 100 or 200 times as potent. A lot of that has to do with how tightly and how avidly it binds on that specific receptor compared to any other receptor, even more so than xylazine. Interestingly, we did get this question, and it's a common one, we don't seem to see the same wound-causing effects from medetomidine as we did with xylazine. And there are some hypotheses about the pharmacology and other receptors, maybe kappa receptor agonists from xylazine that dexmedetomidine and medetomidine doesn't have. But it doesn't seem that we see the wounds. One of the concerns we do have is that as xylazine kind of went away, there's certainly reports in Philadelphia of a decreasing presence or prevalence of new wounds. I would have concerns that if it's rising again in the supply, that we could see those wounds come back, as well as all of the medetomidine effects. So those are things that we'll continue to monitor. So what is alpha-2? When I talk about alpha-2 receptors, what do they do? So they are receptors on the blood vessels that initially, when a drug that turns on alpha-2 receptors, so I'll use the term agonist a lot, basically means something that turns on a receptor. When it gets to those peripheral blood vessels, that response can make them squeeze down a bit. And so you'll see, particularly out of Chicago, but we see it clinically as well, very early after use, we can see that squeezing of blood vessels causing a high blood pressure. And when the blood pressure goes high, there's a reflex that causes your heart rate to go low. But then as it moves into your brain, the alpha-2 receptor, what it does there, it's really a braking mechanism, a slowing mechanism for your adrenergic or your adrenaline response system. So it just kind of turns everything down. It slows your heart rate, it turns down your blood pressure, and it causes sedation through a number of different places in the brain, as I have here. But the key things are that it causes people to be sleepy, and it causes their heart rate and blood pressures to go down after maybe that original or short-term high blood pressure effect. And so what do we see? That fits very specifically to what we see with acute toxicity. Those are some of the questions we got, is how does it look and how does it compare to maybe other acute toxicity? So almost always medetomidine is found in conjunction with fentanyl and opioids. I say almost because it has been identified with other drugs, including stimulants, though usually also with fentanyl. So maybe you have methamphetamine, cocaine, plus small amounts of fentanyl in medetomidine. And then there have been fentanyl samples that have been submitted, particularly in Allegheny County, that have no fentanyl and only have medetomidine, xylazine, and a variety of other sedatives. But usually, almost always, it's found in conjunction with fentanyl. And so the initial findings won't look much different than just a pure opioid toxicity. People will be very sedate, potentially with low or no breathing. As somebody, if they're reversed, or the opioid effects aren't there or are reversed with naloxone, what we expect to see is then prolonged sedation, because the naloxone doesn't reverse any of the medetomidine effects. You may still have meiosis, which is the small pupils, which obviously we mostly associate with the opioid, but this also, the alpha-2 receptor agonist, can do that as well. The low heart rate, which is pretty much always present, and that can be in the 30s or 40s. For clinicians in the audience, it's a sinus bradycardia as opposed to a heart block, at least is what we've observed. You can have that short-term high and then followed by low blood pressure, which can last for several hours. Typically we've seen the top number of blood pressures as low as in the 70s and 80s, and still maybe a little bit of a slowing of the respiratory rate, but not complete cessation of breathing. So most people keep breathing, but it might be a bit slower than you'd expect with part of the overall sedative effect. So how do we manage it? It's really important that we still emphasize the importance and effectiveness of naloxone in doing what it's always been intended to do, which is reverse opioid toxicity. The opioid portion of acute toxicity is still by far the most deadly part of an exposure. So we still want to give naloxone. And actually, naloxone, really nothing changes. The goal is still to reverse respiratory depression. It's actually never been to wake people up. And I think that it's just important to re-emphasize that to folks who might be, whether they're bystanders, EMS, hospital-based professionals, basically anyone, family members who may be using naloxone, that the goal is to see somebody breathing again. And if we see them breathing again, then we don't need to give more naloxone. And that's particularly true for EMS providers who have the ability to monitor, oxygen saturations and things like that. So that should still be given, but we know that it won't reverse the medetomidine or any other alpha-2 agonist like xylazine, so people may stay sleepy. The respiratory treatment, most patients, even though their respiratory rate might stay a little bit low, we find still breathe adequately to keep their oxygen levels up and breathe off carbon dioxide sufficiently. People might have aspiration or other lung problems that require more management. Mostly we're just giving supplemental oxygen. Occasionally we need to put people on ventilators, but that's pretty rare unless they have some other complication. The hypotension or low blood pressure, most of the time, if we are able to get IV access and give IV fluids, most of the time the blood pressure can be raised adequately to perfuse their organs. So it's pretty uncommon that we have to give medications or drugs to artificially elevate their blood pressure, but occasionally we do. And rarely, if ever, do we treat the low heart rate all by itself. So if they have low heart rate and low blood pressure, we might temporarily give something that artificially raises the heart rate. But if their blood pressure is getting blood flow and oxygen to their body, then we don't need to raise their heart rate just to make the number look better. And in fact, if their blood pressure is very high in that early stage with the low heart rate, you can actually cause complications by giving medicines to raise the heart rate, which might actually further increase that blood pressure. So we rarely have to do that, and typically that's going to take place in the hospital and maybe by paramedics. We look for other issues that can complicate essentially any acute toxicity, rhabdomyolysis or muscle breakdown, especially if somebody's been laying for a long period of time without moving. Other issues, right? We always have to be careful about not anchoring to the new thing, right? And we've seen this happen, in areas where acute toxicity is common, where folks just assume that's what's going on, and then they miss other important problems because they just, kind of tractor beam straight onto that thing and forget about all the other possible problems. So we want to keep a close eye on that. And then I've gotten questions about a drug called atipamezole. And this is approved for veterinary use as an alpha-2 agonist reversal agent. So like naloxone for opioids. And so a reasonable question is, if this medetomidine is causing so much problem, should we be looking to get a reversal agent out and approved and used? And at this point, my recommendation and sort of the general toxicology emergency medicine community recommendation is no. And the primary reason being that acute toxicity is certainly a problem and it needs to be managed, but by itself is rarely fatal. But the withdrawal from medetomidine is very serious and has caused really serious problems. And so if we take somebody who maybe is, sleeping for a long period of time, but otherwise being monitored and doing okay, reverse that and put them into severe withdrawal very quickly, particularly then having blocked the very receptors we want to treat, we could cause problems that weren't already there. So at this point, there probably are very narrow targets where this could be utilized, but for broad distribution, kind of like naloxone, would not be something we would recommend. A lot of questions about testing. Very good, appropriate. I have many questions about testing. At this point, there are no FDA approved or cleared clinical tests. So we have no urine, dips or anything like that to test somebody's urine or blood samples for medetomidine in a clinical setting. Advanced testing like liquid chromatography mass spec, if you have that on site, I'm lucky to work somewhere where we do. We can do testing to look for medetomidine. In that that setting, or send off to a reference laboratory like NMS or those kinds of things. They can find it. For the most part, because the half-life is very short, we're mostly having to look for metabolites, so 3-hydroxy medetomidine or medetomidine glucuronide, which actually takes some other processing of the samples to make sure we can find them, because the actual parent compound medetomidine goes away very quickly. I'm getting into some detail because there were some questions about that. And in fact, when we were verifying or connecting this to the syndrome very early on, that's what we had to do both at our shop and in Philadelphia to make sure that it was definitely medetomidine and not something else in the supply. But the metabolite testing was very important. But we do have drug checking. So we can't test human samples, but we can test drug samples or residual supplies and things like that with medetomidine test strips. And those are available. We can get them from our county health department. We're giving them out in some of our EDs, other organizations that we partner with as well, to be able to test supply. So people who use drugs can test and know if they're being exposed and provide that information to providers, or if providers have the ability to test right now. And I'm hopeful, and I got questions about when is testing going to be available. I don't know that. I'm certain that that is being rapidly looked at, given all of the attention, rightful attention. But at this point, I don't see that sort of coming in the next month or two. But hopefully very soon we will have drug testing to look for it. But again, we'll need to target probably the metabolites, particularly by the time somebody's going into withdrawal. We actually rarely find medetomidine. We almost always are finding the metabolites. So I've already sort of hinted at, and I think many people here who have had experience or read about or are here were mostly interested in the withdrawal, as that seems to be causing the most severe complications. So what does it look like? So typically the onset can be very rapid, often within 4 to 6 hours of somebody's last use. And so this was early on when we were seeing this was one of the things that sort of triggered us to know we were seeing something very different. People were coming in, providing very clear history about their use patterns, and saying, I used 4 or 5 hours ago and I feel terrible right now. And they look terrible. They had a lot of nausea, sweating, diaphoresis, not so much piloerection or goosebumps, but otherwise looked like they had opioid withdrawal symptoms, but they had just used. And while fentanyl can certainly be associated with symptoms fairly early after use, usually we aren't seeing that sort of, COW scores of 10, 12, or 15, 4 to 6 hours after use. So that triggered us to know we were seeing something different. The other experience we've had, particularly now as we've gotten more attuned to looking for it and being prepared for it, is that it doesn't always start that soon. So we also see patients who might come in 4, 6, 8 hours after use with minimal or almost no symptoms, or even some residual low heart rate. So the heart rate's in the 40s. They're not really having a lot of withdrawal. They have no residual intoxication effects. And we also see patients not showing really severe withdrawal symptoms out to maybe 20 to 24 hours. Not that they don't have any symptoms, but we've seen plenty of patients where we watch for a long time in the emergency department, sort of think, okay, they're doing okay, and either refer them to a residential or admit them to an inpatient level 4 withdrawal management site, only to have them either come back or transition from the inpatient withdrawal management site to an ICU 20 to 24 hours after that admission or last use. So the timing of onset is very variable, and that makes it really challenging as we're trying to figure out ways to manage and help with disposition. So I just want to call that out very early because it's a common and good question. The other part, severe nausea and vomiting. When I say severe, I mean refractory to lots of treatments. Just people are miserable with the nausea and vomiting. Typical medications that we give, like ondansetron, seem to have almost no effect. And then we see really high heart rates and blood pressures. So typically those symptoms, anxiety, diaphoresis, maybe some tremor, severe nausea and vomiting, those are the first signs and symptoms, but then we rapidly after that start to see heart rates go up, and we see them go to 170s, 180s, 190s. They don't always go that high, but they can. So as it's getting into the low and mid 100s, we see that coming. And then blood pressure is where systolic blood pressure is the top number, can be in the 170 to 230s. I've seen as high as in the 260s for that top number, and the bottom number also going very high. We see some shaking or tremor or jerking activity. It's not clear that these definitely cause seizures. In fact, having cared for at least hundreds, if not more than 1,000 of these patients at this point, it doesn't seem that it causes true seizures for the most part. The few times that true seizures have been verified, oftentimes there's a mixed withdrawal syndrome with GABA agonists, benzos, or alcohol. But it can be hard to differentiate, particularly if somebody is getting confused or agitated as well. We see people develop delirium, encephalopathy, which is not expected with opioid withdrawal, for example. We can see that with GABA agonist withdrawal. As we've gotten more aggressive and better about treating this early, we see less progression to that, but it can happen. And then early on, as we were identifying this, we were seeing 3/4 to 90% of the patients we were seeing in the ED ended up admitted to the ICU. Those percentages have drifted down. I think one, as we get better at diagnosing it, so our denominator is getting bigger, and finding some of those patients maybe with less severe manifestations, but also trying to treat more aggressively early. I think we are able to divert some patients from the ICU, but some patients, no matter what we do, still end up needing the ICU. So when you list all of these things and you just say like tachycardia, hypertension, tremor, it sort of overlaps with a lot of other withdrawal syndromes, including benzos and alcohol. But if you've seen it, and I can say as somebody who's seen it a lot, it's very different. It is much more intense, much more severe. And typically the response that I get when I'm describing it to folks where maybe it's just coming around, or maybe there's only been a couple of cases, is usually like, oh, that's what that was. That really severe case where we had to admit to the ICU, and they got intubated. We put them on propofol and all these sedatives, and nothing was working, and they were vomiting, and no meds we gave worked, and nobody knew why. That was exactly my experience early on as well, all of those things. And so that's commonly what people experience early on until they start to recognize that that's likely what this is. Other complications, anti-GAP metabolic acidosis, lactic acid level elevations up to 6, 7, 8, 9 have been levels that we've seen. Low potassium levels. If you get an EKG, we commonly see a long QTC, probably partially related to all the metabolic changes, the potassium levels and things like that. We think about that with the medications that we have to give, but frankly, usually the heart rate is fast enough that it's somewhat protective to complications of a long QTC like Torsade, which we have not seen despite a pretty common finding of QTC prolongation. See myocardial injury with troponin elevation. So troponin's going way up, and sometimes with associated cardiomyopathy, where the ability to squeeze actually is reduced, particularly if it gets advanced with the really persistent high heart rate and high blood pressure. Important reasons to get those things under control. And then complications of the high blood pressure in the brain. So resolving encephalopathy syndrome, or PRES, which can happen with high blood pressure and gets better, potential for strokes and things like that, or hemorrhages because of the high blood pressure. So all of these things are things that we've seen with this withdrawal syndrome. So how do we manage it? Sort of the early management is going to be with, oral medications to the extent that the patients are able to take oral medications, right? So we are very aggressive with clonidine. There's different ways of doing this. So some places will give 0.6 milligram doses, and then maybe repeat that every hour. We often are giving 0.3 milligram doses just to kind of ensure that we don't see, for folks whose heart rates and blood pressures might not be too high yet, and then give that up to 3 times within an hour, just to make sure we don't kind of overshoot, but really all of those different attempts are trying to get clonidine in somebody's system early and at high dose. So, this can give them about 1 milligram in that first hour. And then we put them on standing doses of 0.3 milligrams every 2 hours. And we use a COWS protocol every 2 hours to give additional clonidine of 0.2 to 0.3. And what that means is every 2 hours, a patient could get up to 0.6 milligrams of clonidine. Of course, we monitor their heart rate and blood pressure, with that. So if their heart rate and blood pressure are low, then we have holding parameters, but we're still giving it because we're finding that and this isn't how we started, this is where we are now, because every time that we get more aggressive, we find that we need to keep getting more aggressive. And part of the goal is to try to keep people out of the ICU if we can. We also simultaneously start guanfacine immediate release, 2 milligrams every 8 hours. And the reason for that, it's a bit longer acting than the clonidine, is to try to give something that is longer acting that might reduce the need for those PRNs. And usually that standing clonidine we stop after 24 hours and then just keep that PRN and the guanfacine standing. And then also we do a transdermal clonidine at 0.3 milligrams. So all three of these things we start simultaneously in the emergency department if people are able to tolerate the oral dosing, and the transdermal even if they are not. For many patients, they're not able to tolerate the oral medications, or despite all of these oral medications, they just progress to a point where their heart rates are very high, the blood pressures are very high, and so we are loading with dexmedetomidine. The dose that we load with is 1 microgram per kilogram over 10 minutes, and then we start in a continuous infusion. Honestly, we typically start at 1 microgram per kilo per hour now. Historically, the infusion range was 0.5 to 1.5. We worked with our pharmacy and critical care folks to increase the top number or the max infusion rate to 2.4 because we're finding many patients just weren't getting adequate sedation on 1.5 mics per kilo per hour. So we had to increase that. I know that other places have started to do the same with different top numbers that depend on a lot of things, depending on your work with your pharmacy, pumps, protocols, all of those kinds of things. But every time, like I said, that we do something, we find we need to get even more aggressive. Most of the time, after about 24 to 72 hours on the dexmedetomidine, we're able to wean them off. As we get control of the nausea and vomiting, as they're on the dexmedetomidine, we still give or restart those oral medications to help reduce how high we need to get on the dexmedetomidine, as well as to help wean it off. And so sometimes in less than 24 hours, we're able to wean the dexmedetomidine, but sometimes we try and then we have to go back up and people aren't able to get off of it. And then once we're able to wean off, then we continue with the oral medications only. Once people aren't needing their PRN clonidine anymore, then we start to taper the guanfacine. 2 BID to 1 TID to 1 BID to 1 daily. So you can see about a 5-day taper there from the 2 milligrams Q8 hours. So that can be done either in the hospital or other residential facility, or we sometimes give folks prescriptions to finish that at home, depending on how they're doing. And then there were questions submitted, and we have the same questions about discharging with an alpha-2 agonist. And the short answer is we are. The longer answer is we don't know how much, how long, or the right dosing regimen. Often we're using clonidine and giving people 0.1 or 0.2 milligram tablets to take, initially every 8 hours or so as they need them for craving. There's an open question about the degree to which medetomidine itself induces cravings, urges to use versus the opioid or both. But what we're finding is lots of folks, because you develop tolerance very quickly, potentially over a week of use, that by the time after a week, if you discontinue, you can go into withdrawal. We're finding a lot of people get treated, discharged from from the hospital, return to using, and then get readmitted, within a month, essentially, need to go back to the ICU. And talking to folks, there certainly seems to be a degree of craving or urge to use linked to the alpha-2, separate from the opioid itself, which we're also treating with bup or methadone. So we have started using clonidine for longer periods of time, up to a couple of weeks. How long to do that and how best, we don't know. So I don't specify what to do here, but I do think that continued regular check-ins, and this is what we're doing with a lot of our outpatient providers, is continuing those medications and tapering them more slowly over time, but we don't have a set protocol for that yet. Other important things, of course, we also need to manage their opioid use disorder and opioid withdrawal. So there are overlapping symptoms, and I think what becomes important is that you can't really use a typical COWS-based buprenorphine induction protocol because their COWS scores are going to be high, right? COWS is not really specific to opioid withdrawal. A lot of it is just feeling really bad, right? So people going through medetomidine withdrawal will typically have very high COWS scores, even if it's only been 4 or 5 hours from their last use. So if we use that to do a typical buprenorphine induction, we might also cause precipitated withdrawal. So we tend to use a low dose or microdose induction in the hospital. People can still be induced on buprenorphine, probably more in a time-based protocol. So, thinking 24 to 48 hours after last use with comfort medications and either a low or microdose induction protocol or a macro dose, but again, waiting that 24 to 48 hours from last use to reduce that risk of precipitated withdrawal. Methadone can be initiated immediately, of course, and we use a lot of methadone as well. So the methadone and buprenorphine don't treat medetomidine withdrawal, and they don't treat medetomidine use, right? They're completely different receptors. So they're really important to use. They don't make anything worse about medetomidine withdrawal unless we precipitate it with buprenorphine too early. But it's really important that we start that in parallel with the medetomidine withdrawal management to make sure that opioid use is treated, so when people leave that they have appropriate control of those urges and cravings. Again, whether it's buprenorphine, potentially higher dose at 24 to 32 milligrams, just as evidence has grown to support that, or methadone and transition to an OTP, both are appropriate and effective. We do monitor the QTC. As I said, it can be quite long early on, but again, we don't typically see complications of it, and it often improves over a day or two of treatment, but still something to keep in mind with methadone induction. And then other supportive things. I mentioned that antiemetic, so ondansetron, does not seem to be very effective. We tend to see better response to dopamine antagonists, so medications like prochlorperazine or droperidol or olanzapine. There's variability in people's preferences and practice patterns and so forth. There's definitely no evidence to support one definitely being better than the other, but those, based on experience, all seem to be better than ondansetron. There are other things like trimethylbenzamide or even scopolamine patches that have been used. Some patients, in addition to the alpha-2 agonists, so clonidine, guanfacine, or dexmedetomidine, might need medications directly targeting their blood pressure, like in the hospital, to lower it, given the potential complications. And then also monitoring for co-occurring syndromes or just extreme anxiety and agitation. So things like benzodiazepines and phenobarbital do not treat medetomidine withdrawal well. Early on, when we didn't know what it was, we were giving big doses of benzos and barbs and really not getting much benefit. You might start to see some sleepiness, but the heart rate, the blood pressure, the shakiness, the nausea and vomiting, they weren't improving. So I still use these in conjunction with everything else when people are very anxious, but definitely not on their own. And then, as we know, polysubstance use is very common. So anybody also going through a GABA agonist withdrawal, we want to make sure we don't lose control of that as well. So giving benzos and barbs certainly appropriate. Ketamine was discussed particularly early on when we didn't know what we were treating yet. These days, I rarely employ that for the management of these patients. We really just try to emphasize being aggressive with the alpha-2 agonists. So this is published, a manuscript. This kind of outlines more or less what I just described, and it's really for hospital use. So this was published in the Annals of Emergency Medicine. I'm not going to go through it. I know it's a busy slide, but it's really a summary of all the things we just discussed. And in fact, if anything, we continue to get more aggressive, even from this, which was published about 5 months ago, because that's what we keep having to do, is keep getting more and more aggressive. So what's been some of the impact? The severity for a lot of these patients will preclude admission to residential facilities, 3.7s even, that have lots of capabilities, or outpatient management. If somebody needs the ICU, they really can't be managed anywhere else. And as we know, a significant proportion of these patients need the ICU. At the same time, all patients with opioid use disorder don't necessarily have medetomidine withdrawal. So we can't have every patient who might be at risk potentially all going to the emergency department or being admitted to the ICU for the potential, because capacity is significantly strained. We know that EDs are already struggling with boarding and overcrowding and things like that, which, impact all patients, who may not then get the treatment they need. And the more patients we have there, the more that can be impacted. We also know that has to be balanced with, if they can't be managed anywhere else, then they need to go there. I'll get into a little bit, and I'll move quickly now, recognizing the time, how to try to make some of those decisions. I'll be very quick here. This is just showing that in our emergency department at UPMC Mercy, where I primarily practice in the ED, you can see our just opioid withdrawal visits to the ED more than doubled from 2023 to 2025, when medetomidine, as we saw, was quite prevalent in our county. The percentage who need to be admitted more than tripled. So people with opioid withdrawal rarely got admitted to the hospital. That tripled. The percent of people admitted to the hospital who needed to go to the ICU for opioid withdrawal as a primary diagnosis, because there isn't a diagnosis code for medetomidine withdrawal, went from none to 40%. So you can see just people with a diagnosis of opioid withdrawal, the impact that had. Something that we're looking at is, so we know medetomidine is present sort of in varying degrees all over the place, but we also know, and there are Department of Health data that tell us that not everywhere is seeing lots of withdrawal, right? Going to, the urban centers are seeing a lot more ED visits and encounters and hospitalizations for withdrawal. We're seeing more and more in rural areas as well, but not to the same degree. And we know that, and even just looking at some of the responses to the registration, in a lot of rural areas, they're seeing it, but not much at all. And even some places in Pennsylvania aren't seeing it really at all yet, or at least not that they're aware of. So why is that, even though we know it's sort of present everywhere? And it probably has to do with how much is in the supply, both the concentration and how much of the supply has medetomidine in it, because you have to have consistent use to your body to get used to it, such that when you stop it, you go into withdrawal. So probably it needs to be present in at least 10 or 20% or more of the supply, that somebody in an adequate concentration, that people will get it enough in their system that when it goes away, they have withdrawal. And this graph kind of shows that in our system. We saw ED encounters go up early at 10 to 20%, but as it got to 40+% prevalent in Allegheny County, the encounters kept going up, but then the percentage that needed to be admitted to the hospital also went up, even though the denominator was getting bigger. So just, sort of more of a hypothesis than anything else, but it would seem to make sense. So how do we approach that? Because a common question and a good question, the important question is, okay, so you said that many need to be admitted in the hospital or the ICU. I treat patients in an outpatient or a residential facility, clearly don't have the ability to treat someone with ICU level care. You also told me that it might be up to 20 to 24 hours before somebody shows really severe symptoms. How can I predict who's going to and I can't test for it. So how can I predict who's going to have it? And those are the right questions to ask, the questions we ask every day, and still have difficulty answering. So I'll be very honest about that. There is no definitive answer to that really good and important question. one thing is understanding local drug supply to the extent that you can. Is medetomidine present? Is it present in more than 20% of the supply? So whether you have drug checking from somewhere like PA Groundhogs, or you're able to do that, you're in a county that's able to test for it, or you get test strips out to people who use drugs and are able to gather some degree of understanding of how common it is. Because if it's not in the supply locally, you probably don't need to worry about it too much. But if you know that it's in your supply and it's increasingly in your supply, then you got to move on and recognize, okay, some of my patients are going to go into this. People who've had this complicated withdrawal in the past certainly are going to be at risk, which is typical of how we assess withdrawal and other things. The drug checking data we talked about. If they have repeated toxicity where they stay sleepy for a while, or they stay with a low heart rate, or they're able to present to you and their heart rate is persistently low in the 40s, those are all things that might say to you they're more at risk for going into withdrawal. And if you are in one of those residential or other facilities, are you able to try aggressive oral alpha-2 agonists? Maybe not quite as aggressive as we're being in the hospital because we can put people on monitors, but give that clonidine 0.3, up to a milligram in that first hour. Kind of check in with them, give them 0.3 every couple of hours while you're monitoring, check intermittently their heart rate and blood pressure. Keep them on the cows. Be very aggressive with antiemetics. And if you do those things, and despite doing that, they're progressing, their vomiting is uncontrolled, or you check their heart rates and blood pressures and they're going up to a point where you're not comfortable, heart rate's 120, blood pressure, systolic top number is 180 or higher, and you're like, we're giving these meds and it's just not working, or the patient just looks and feels terrible, or they're going to leave because they feel so bad, then you have no choice but to refer them to a hospital. And you'll get this, I think you'll get the slides. This is basically just an adaptation. It's available on the Substance Use Philly site as well, of our inpatient, but just only with all the things that you can do that don't require hospitalization, and sort of summarizing that if all those things aren't working, then you probably need to send them to the hospital, essentially. So, and the questions have come up. Is there a role for long-acting alpha-2 agonists? I would love that. I think there's a really, and I know that this is being evaluated by pharmaceutical companies and things like that, can we do like an injectable, almost like a long-acting injectable buprenorphine, but for alpha-2 agonism, to sort of control cravings there? Obviously, there's a lot of questions about making sure you don't have adverse effects by too much lowering heart rates and blood pressures and making people feel lightheaded and dizzy and those kinds of things. Is there a separate alpha-2 agonist tolerance? Well, definitely tolerance, but addiction, or craving or urges to use that are separate from the opioid use? Very hard to disentangle since they're mostly together. My early, I suppose that it probably is a separate addiction as well. And that's based on talking to patients and also experience of getting people on to really, high dose buprenorphine, long-acting injectable buprenorphine, therapeutic doses of methadone before they leave the hospital, where they report controlled cravings of their opioids, but they still have some craving to use that they feel like is separate from the opioids. And that's, again, hard to ask and hard to know for patients and for providers, but it seems that there is something there, at least for some patients, that is more than that urge to go back to using opioids, which we know has always been the case. Are there ways to keep people out of the ICU or even out of the hospital, using things like intranasal or sublingual dexmedetomidine, which we use for agitation associated with schizophrenia or bipolar disorder? Can we dose that in a way out and that doesn't need an infusion, which requires the ICU? IV clonidine is potentially available. And then also knowing and following with our drug checking and other community-based providers and people who use drugs, and knowing what's the next thing, with nitazines and now cyclorphins, other alpha-2 agonists, other sedatives, antipsychotics. What's going to be the next thing that kind of becomes very prevalent in the drug supply, and try to recognize it early, recognize any changes that we need to make early, and try to get those things out as quickly as possible to try to stay ahead of it in places that haven't seen it yet. And I think we need to keep working on that. So that's the summary. I will cede control back to my friends at DDAP with a few minutes left. I'm happy to stay on and answer questions now and beyond 11 o'clock.
Thanks, Dr. Lynch. There were a few questions. I don't know if you wanted to take one or two in the chat.
Yeah, if anyone's been following and can summarize for me, because I have not been following the chat and I want to have to read and answer.
Someone asked how long after dexmedetomidine infusion is stopped is it safe for discharge to a residential rehab facility?
Yeah, I mean, I would say probably about 24 hours. What we find, and as bad as it is, we often find that people, once they start getting better from an acute withdrawal standpoint, they tend to get better pretty quickly and are, over the course of another day or two are ready for, honestly, hospital discharge to anywhere, including home. I think the piece that we're still working on, and honestly, this is where I think partnering with residential facilities would be really important, is how long to consider some of that alpha-2 therapy for cravings and understanding it and working with them in a controlled environment. Obviously, not every patient needs residential treatment, but those who do and would benefit from it, I think addressing that and understanding that and continuing those therapies, and reassessing will be really important. Things I can't do in the hospital, and obviously in office-based settings, there's just such a patchwork, it's hard to follow in a consistent way. Great question, though.
And then there's another question about is methadone or Suboxone effective at all with these drugs?
They remain effective for the treatment of opioid use disorder. Obviously, we all know that the data have been clear for a very long time. Having said that, as with anything, a single medication is not sufficient to treat any disease, essentially, including addiction. And medetomidine and other things complicate the management. So they're really important to get people on those MOUD medications, but also recognize that they don't really address anything related to the alpha-2 agonism. And we also know that the additional supports, behavioral therapies, social supports and interventions, peer support, all of those important things for addiction management remain critical, but those medications are still sort of core and central to managing opioid use disorder, which is complicated by this.
Yeah. There's another question about, do you consider how much someone uses per day as well as a percentage in the local supply?
I do, but qualitatively, right? It's hard to know, even in places like Philadelphia and Pittsburgh, or Allegheny County, where we have pretty good and fairly up-to-date drug checking data, right? I mean, that is dependent on what is submitted to be tested. And maybe what I'll use Pittsburgh area. If I'm using in Penn Hills, my supply may be very different than if I'm using in Mount Oliver, right? And maybe in Mount Oliver, 80% of my supply is medetomidine, and the 20% of any sample is medetomidine. In Penn Hills, it might be 40% it has medetomidine, only 3% concentration, right? And so what are the differences there? I don't know. So I use it as an awareness, a background awareness, and that's sort of how I recommend in other areas, if you can even get that kind of data, is just a general awareness. It's out there to a large degree, to a small degree, but for an individual, there's no good way of saying this is very tailored to you specifically. And then that's where asking them, if they do check their drugs and they do it regularly, how commonly is it coming up positive for medetomidine? And then you can have some idea about that individual, but they won't know the concentration. That's still very difficult data to get, but places are doing it, like CFSRE.
Yeah, that's great. Well, I know we only have a few minutes left and there's still a few more questions, but we just want to thank everyone for joining today's session, and that we will, if you have additional questions, we have a link that you can submit your additional questions to, that we can hopefully compile a Q&A document to be posted, as well with the recording and presentation slides. The slides will be shared out after via email, but they'll also be available on our webpage. And then next slide, we do have our next quarterly technical assistance webinar call on Monday, July 6th at 10 a.m. And this will be a fireside chat with behavioral health managed care organizations. So the registration will be coming out soon via our new communications platform for email updates. So that is all we have. There also is some additional references and materials we have then the slide deck that will be shared out as well. So that's it.
Thank you, everyone. Thank you for coming and your attention. Appreciate it. Just quickly, if we're still on, I see a cyclorphin question. Hard to know specifically. Cyclorphin is being identified in small numbers so far, but it is a next opioid that we are very concerned about, much like nitazines, which we saw some rise in, and then those have kind of not developed into a really highly prevalent, but you never know which one will. And cyclorphins are similar in that they're more potent than fentanyl generally, and longer acting. So something we're keeping a close eye on in our drug checking and biological sample testing partners are as well. So a great question, something that I'm certainly keeping a close eye out for.
Yep, we're also keeping an eye at the state level, so.
And just want to reemphasize that there has never yet been an opioid that does not respond to naloxone. And that includes cyclorphin. It, whether dosing or dose frequency or recurrent dosing, timing, things like that could change, but giving naloxone and monitoring for restoration of breathing has been and continues to be the recommendation, regardless of the opioid, so that there has yet to be a naloxone-resistant opioid.
What was the other name you said? You said the cyclorphine and what? And what was the other one?
Nitazines.
How do you spell that?
Nitazenes. And there's like isotinidazine, medetomidine. There are several, but Nitazenes. And I can put it in the chat.
Thank you.
Those were identified sort of. It's the meeting. It's not there anymore. But those were identified a few years ago, and they continue to be present, but in pretty small numbers and overdose deaths, and basically found that naloxone still worked, but more patients needed another dose later because of a longer acting. Not so much they need higher doses, they just needed another dose more often compared to fentanyl. But again, it's been minimally present, fortunately, and hopefully it stays that way. Fentanyl is bad enough. We don't need anything stronger or longer acting.